Hi, I'm Peter Gloviczki from Mayo Clinic, editor-in-chief of the Journal of Vascular Surgery, Venous and Lymphatic Disorders. Let me wish all of you first a happy new year of 2020. We are pleased to introduce 4 outstanding papers of the January issue of the JVSVL. You can download all of them this month free of charge. The Editor's Choice article, that is also our CME article, is entitled Quality of Life After Pharmacomechanical Catheter-Directed Thrombolysis for Proximal Deep Venous Thrombosis, written by Dr. Susan Kahn and colleagues for the ATTRACT trial investigators. In the ATTRACT trial, as you remember, the pharmacomechanical catheter-directed thrombolysis did not reduce the occurrence of post-thrombotic syndrome during 24 months of follow-up, but reduced the severity of post-thrombotic syndrome and accelerated resolution of acute symptoms. In this analysis, the quality of life of all patients who participated in the ATTRACT trial was investigated. In this randomized control trial, 691 patients with proximal, that means femoral popliteal or iliofemoral or both, deep vein thrombosis, were randomized to catheter-directed thrombolysis with anticoagulation versus anticoagulation alone. In the entire group, pharmacomechanical catheter-directed thrombolysis resulted in greater improvement of disease-specific quality of life as measured by the venous insufficiency epidemiological and economic study on quality of life symptoms. That's the VANS quality of life symptom measure. Then controls at 1 month and at 6 months. In patients with iliofemoral DVT, pharmacomechanical catheter-directed thrombolysis led to greater improvement in disease-specific quality of life during the entire follow-up of 24 months versus anticoagulation alone. So the take-home message of this paper is that pharmacomechanical catheter-directed thrombolysis may indeed be a reasonable treatment in selected symptomatic patients with iliofemoral DVT who are at low bleeding risk and have the willingness to undergo a catheter-based procedure. The next paper I'd like to introduce dealt with spontaneous hemorrhage from varicose veins, written by Dr. Amrit Hingorani and colleagues from Brooklyn, New York. In this retrospective study, 32 patients, that was 4% of 808 varicose vein patients, were treated with hemorrhage from varicose veins. 50% of them, 16, presented with bleeding after coming into contact with warm water. All patients were treated with Unna-boots. 20 underwent vein ablation for incompetence. The skin defect or ulcer healed in an average of 2.12 weeks. Those with bleeding after warm water exposure had significantly faster healing rate than those who did not. The take-home message from this paper is that spontaneous hemorrhage from varicose vein is an uncommon but potentially fatal complication, and also that varicose vein hemorrhage is safely and effectively treated with Unna-boots. The next paper I'd like to introduce is entitled Factors Predicting Failure of Retrieval of Inferior Vena Cava Filters, written by Dr. Catherine Morrow and colleagues from Cleveland, Ohio. Overall filter retrieval failure rate out of 295 attempts was 16%. The median filter dwell time was 196 days for the successful retrievals, significantly shorter than the 375 days for failed retrieval attempts. Failure rate was only 4% when filter did not penetrate through the inferior vena cava, or if only the tines of the filter penetrated. And the failure rate was significantly higher, 48%, in those where the hook or the apex of the filter penetrated the wall as well. And finally, 67% of the retrievals failed when the hook, the apex, and the color of the filter penetrated the IVC wall. So the take-home message from this paper is that filters with any significant penetration through the IVC wall will have increased rates of retrieval failure. Filter tine penetration into adjacent structures, interestingly, did not significantly affect the retrieval failure rate. The final article I would like to present today is entitled False Negatives, Upper Extremity Ultrasound in the Initial Evaluation of Patients with Suspected Subclavian Vein Thrombosis due to Thoracic Outlet Syndrome, written by Dr. Evan Brownie and colleagues from St. Louis, Missouri. Among 214 patients treated surgically for venous thoracic outlet syndrome, 21% had a false negative study on initial ultrasound. Now, these patients are less likely to have a definitive diagnostic imaging within 48 hours, and they are more likely to require subclavian vein reconstruction because of delay in diagnosis. And for these reasons, the authors suggest starting anticoagulation even with negative ultrasound in those patients who have a high index of suspicion for venous thoracic outlet syndrome. And we should consider proceeding with catheter-based venogram to rule out venous thrombosis, or proceed with thrombolysis if thrombosis is confirmed. Now, these were just 4 of the many great papers from the January issue of the JVSVL. To access these articles, please log on to jvsvenous.org. Let us know if you have any questions or comments, and see you next time for the highlight of the March issue of the JVS Venous and Lymphatic Disorders.